Thank you, Professor Haitham, for arranging this joint session between ERA and ICRA. A brief introduction. Atrial fibrillation is a common problem affecting an estimated 1 to 2% of world's population across a range of age groups. It creates a large burden of healthcare and socioeconomic costs. AF ablation is an increasingly important procedure with growing demand globally. AF ablation is a relatively safe procedure with a mortality rate of less than 0.1%. Catheter ablation of atrial fibrillation is a complex interventional procedure that has changed along the time. Nowadays, many technological advances have been incorporated in clinical practice in order to improve success rate and minimize complication. Despite that, as the volume of AF ablation procedures grow, the number of complications is also expected to increase. This is a very famous algorithm in 2020 AC guidelines for diagnosis and management of atrial fibrillation. And the guidelines is a class 1 indication to perform AF catheter ablation in paroxysmal and persistent atrial fibrillation with or without major risk factor for AF recurrence. Also in paroxysmal or persistent atrial fibrillation and heart failure with reduced ejection fraction is class 1 indication. This table is presented also in the guidelines with the procedure-related complication with a life-threatening complication of pre-procedural death, esophageal fistula, pre-procedural thromboembolic event, and cardiac tamponade. Severe complication, the most common is vascular complication, but pulmonary vein stenosis and persistent phrenic nerve palsy can also occur. Another minor indication and a complication of unknown significance like asymptomatic cerebral embolism. So the guidelines showed key issues in follow-up after AF catheter ablation in recognition and management of complication that the clinician and the patient must be informed about the clinical signs and symptoms of rare but potentially dangerous ablation-related complication that may occur after hospital discharge like AF fistula and pulmonary vein stenosis. Also, the WAC therapy is continued for 2 months, regardless of Schatz-Vasque score, is a key issue in the follow-up of atrial fibrillation catheter ablation. So the most frequent severe and well-established complication I will discuss is cardiac tamponade, how to avoid cardiac tamponade, pre-procedural stroke, pulmonary vein stenosis, and phrenic nerve palsy. Also the atrial esophageal fistula. Cardiac tamponade with a general incidence of 1.2 to 1.3%. The main reasons for high incidence in AF ablation are the transeptal punctures, the intense and long catheter manipulation in the left atrium, the use of high power ablation with risk of steam pops, and the need for intense systemic anticoagulation. Cardiac tamponade have been considered the most frequent cause of peri-procedural death during AF ablation. Also, the incidence of tamponade suggested to be lower during cryoablation, especially for the recent prospective randomized controlled trial of fire and ice trial by Karl-Heinz Cook that showed a tamponade of 0.3% in the cryoballoon arm as compared to 1.3% in the RF arm. This diagram shows the transition of invasive blood pressure during the procedure in a representative case that required pericardiocentesis. As we can see the start, the blood pressure is almost 140. After transeptal, stable, safe transeptal. Pulmonary vein venogram, it's okay. And then during left pulmonary veins ablation, we can see the drop of blood pressure and the continuation of the procedure till the need of pericardiocentesis. Here is the timing of an overt cardiac tamponade, which clearly shown that most of tamponade occurred during left pulmonary vein isolation. How to avoid cardiac tamponade? Transeptal punctures performed too posteriorly may perforate the posterior right atrium and reach the pericardial space. Very high punctures may also perforate the left atrial roof. Advancing the sheath system too deep into the left atrium may reach and perforate the left atrium appendage, left pulmonary veins, or the lateral left atrial wall. The use of different fluoroscopic views as REO to have a better anterior-posterior view of the transeptal puncture and left anterior oblique to evaluate how depths in the sheath system being introduced in the left atrium may prevent transeptal accident. Also, advancing the transeptal system over the wire positioned in the left superior pulmonary vein is crucial and important as a strategy to prevent left atrial perforation. Recently, many operators like Professor Mervat prefer to use transesophageal echo while doing transeptal for a safer transeptal puncture. Direct catheter mechanical trauma, especially through the left atrial appendage and the roof of the left atrium, are an important cause of pericardial effusion. Here, a diagram showing illustrative TE view of transeptal puncture. A shows septal tending immediately after retraction of the sheath in the bicaval view, as we say the Mickey Mouse view, shows the advanced needle, showing the advanced, figure B shows the advanced needle and the tenting of the transeptal away from the aortic root, which is very crucial, as well as within acceptable distance to the posterior left atrial wall. C shows the catches the instance of septum perforation in the same patient, and D shows the advanced introducer sheaths within the left atrium. Here also a technique used in Stuttgart Smart Ablate RF generator as a core part of technology for closed protocol guided BVI, which offers opportunity to automatically stop RF energy delivery within 0.5 seconds if the catheter impedance rises above a predefined value. The value for impedance spike takeoff is 50 ohm per 0.5 seconds. How to recognize cardiac tamponade? There is a majority of episodes of cardiac tamponade are successfully treated immediately by percutaneous and pericardiocentesis. Early recognition and rapid drainage and detection of tamponade is crucial in the management. An early sign of cardiac tamponade is a reduction in the excursion of cardiac silhouette on fluoroscopy with simultaneous fall in systemic blood pressure. Very early hypotension is also an important sign to take in consideration. Availability of the portable echo machine is important in the EP lab. Also, ICE has been helpful to early detect the pericardial effusion, but in our practice with Professor Mervat, we use transesophageal echo and the portable echo machine, actually a tablet with an echo probe. How to manage cardiac tamponade? Subxiphoid puncture is the best way to achieve a drainage catheter, anticoagulation of patient with warfarin or NOAC without interruption, fresh frozen plasma if the patient was on warfarin, either rosizumab as a reversal for dibigatran if the patient on dibigatran, and dilexanate alpha if on rivaroxaban, apixaban, and edoxaban. This figure shows the echocardiographic subxiphoid images before and after pericardiocentesis. Stroke, cerebral embolism is a critical complication of AF ablation with an incidence of thromboembolism associated and reported to be 1 to 2%. Introduction of peri-procedural management for stroke is crucial. Clinical and technical aspect implicated in the risk of thromboembolic event during AF ablation, like paroxysmal atrial fibrillation, small left atrium, low Chaz-Vasquez score. The four main mechanisms for development of a stroke are thrombus already formed before the puncture and dislodged during left atrial catheter, thrombus formation in transeptal sheaths, we saw that, and also at the tip of the ablation during RF delivery, maybe thrombus at the ablation area, or thrombus formation due to prothrombotic state that occurs after ablation. This is one of Professor Mervat cases. Before going to transeptal puncture, we always use T on table, exclude left atrial and right atrial appendage thrombus. We found before transeptal function this freely mobile thrombus, and we aborted the procedure. How to prevent a stroke? Stroke events have been reduced after applying strict preventive protocol that involve pre-procedural anticoagulation for at least 3 weeks prior ablation. Also, IV heparin is essential to prevent thrombus formation during procedure. Around 10,000 international unit is generally administered after safe transeptal punctures. ACT regularly checked every 30 minutes, and additional IV heparin is infused to maintain ACT around 350 seconds. This is a diagram showing the potential mechanisms that lead to risk of stroke, dementia, and cognitive decline related to the procedure or not related to the procedure. How to recognize a stroke? Arterial occlusion of a major important cerebral artery shows motor deficit, dysphasia, dysarthria, and disorientation. Small arteriole might lead to visual disturbs. Also, asymptomatic cerebral embolism can be seen in MRI after ablation that related to future cognitive deficits. How to manage acute stroke is managed according to stroke protocol, and aggressive early management of acute may attenuate their consequences. It's time to break some ice now with this case, also from Professor Mervat cases. This is a phenomena called intracardiac drifting iceberg phenomena. Following ablation of right superior pulmonary vein, a piece of frozen contrast was detached from the vein to the bloodstream and traveled from the left atrium to the left ventricle while decreased in size. The patient persisted asymptomatic, probably due to thawing of the embolic material during intravascular movement, and the clinical consequences. Yes, this is cryoablation. I'm saying it's a frozen contrast. And the clinical consequences of ice embolism related to cryoablation remain unknown. Pulmonary vein stenosis was the most important complication on the beginning of experience, because the ablation was conventionally inside the pulmonary veins for the foci deep inside the veins, and this scenario changed after antral ablation. How to avoid is antral ablation strategy, of course. Patients undergoing multiple procedures have the high risk of pulmonary vein stenosis, as I will show. Cryoablation, AF ablation strategy show low risk of pulmonary vein stenosis on the expenses of phrenic nerve palsy using a new generation big balloon, as recently demonstrated by the Fire and Ice trial. This is a case, a redo case. We can see the left superior pulmonary vein that showed a stenosis in the redo procedure. How to recognize? Pulmonary vein stenosis symptoms ranges from asymptomatic to severe symptoms. Actually, if a single vein is involved, no worry, the patient might come asymptomatic as long as he didn't get into another session, and we can see a pulmonary vein stenosis during the second 3D mapping and ablation. Common symptoms are cough, chest pain, dyspnea, hemoptysis, and recurrent pulmonary infection. It's important to have in mind that severe stenosis can also remain asymptomatic, as I said, and the percentage of the severity graded according to the percentage of reduction of luminal diameter. That's why early images examination is beneficial. This is an ICE case showing the difference before and after pulmonary vein, left inferior pulmonary vein isolation, with increase in the peak velocity of the left lower or left inferior pulmonary vein. How to manage pulmonary vein stenosis? Asymptomatic or mild symptomatic, even with severe pulmonary, are usually managed. I need 3 minutes. Successful BV angioplasty with a BV restenosis can occur in 50% of cases. And there is no, and the most severe complication of pulmonary vein stenosis intervention are tamponade, massive bleeding, pulmonary vein rupture. This is an interesting case showing the recanalization of an occluded left inferior pulmonary vein with a CT pre and post procedure and angiography pre and post intervention. Phrenic nerve palsy in the past, the right phrenic nerve palsy is an important complication of AF ablation, but currently after introduction of cryoablation showed in the Fire and Ice trial that the incidence of a persistent phrenic nerve palsy was 0.3%. Attempts to isolate the superior vena cava also carry a very high risk of right phrenic nerve palsy. This is the anatomy of the right and left phrenic nerve as it goes, the right nerve around the SVC and the dissected left phrenic nerve across the lateral border of the left ventricle. This diagram shows the occurrence of phrenic nerve palsy, which is very significant in cryoballoon arm. How to avoid phrenic nerve palsy is to avoid delivery of RF in recognized sites close to the phrenic nerve. As I said, for non-BV triggers, if we go to SVC isolation, there is a 10% chance of persistent phrenic nerve palsy. This is the various maneuvers used to prevent phrenic nerve injury, ranging from avoid long-acting paralytic during ablation till the utilize of the pull-back method to assess the depth of balloon inside pulmonary veins, with pros and cons of various phrenic nerve monitoring strategies. This is schematic presentation of one technique to avoid diaphragmatic injury. This is a proximal seal technique used during cryoablation with a simultaneous 3D mapping system to identify and annotate the phrenic nerve course, and after getting inside the vein, getting a little bit out, after ensure the seal of the dye inside the pulmonary vein. How to recognize absence of diaphragmatic excursion on fluoroscopy, new elevated diaphragm, as this is the position of catheter during superior vena cava placement of a decapular catheter to ensure a phrenic curve capture during right superior pulmonary vein cryoablation. Just 30 seconds. How to manage phrenic nerve palsy? Okay, I will get into conclusion. This is also the atrioesophageal fistula with diagrams to avoid and recognize atrioesophageal fistula. And this is the flow chart. To conclude, a proactive and alert EB team is the one and only approach to avoid life-threatening complication of AF ablation. Pre-procedural monitoring of the borders, phrenic nerve injury, ACT, blood pressure, and worrisome symptoms in the follow-up for as soon as possible recognition and prompt aggressive management of complication. So don't ever fire or even freeze and forget, as your patient might face a dramatic deadly end. Thanks for your listening.
Thank you, Salah.
Yeah, that's the era slides. I will show the era mission, which is improving the quality. Which improving the quality of life and reducing the sudden cardiac death by limiting the impact of heart rhythm disturbances. This is the EXCO members with Professor Jose Merino, the president. The upcoming ERA meeting will be in Berlin from the 7th to 9th of April. There is a lot of upcoming webinars, educational courses, and of course the EP Europace journal. We want to apply for an ERA recognized training centers. If any center is eligible, can apply for the recognized training center like critical care unit in Cairo University. There is also ERA books and website for patients, and the key messages in the Pocket by ERA Key Messages application. The AEC e-learning and the cardiology education hub shows 2 tracks, device track and EP fellows track. The key reference library with 400 cutting-edge publication. So join ERA for a new single ERA Silver membership and get the benefits. Under 40 or still in training, ERA is providing a discount on the membership fee. ERA is your community for career education, science, and of course the Congress. Recognition of excellence is for a fellow of ERA like Professor Mervet is a fellow of ERA. ERA Scientific Initiative, to join the ERA Scientific Initiative research and surveys. And finally, meet the ERA news on Twitter and LinkedIn. Thank you.
Thank you, Salah.